Good morning. Thank you very much for having me. I'm Ozturk. I'm at the University of Pennsylvania. This is my first Innovasis meeting, so I want to thank the chairs for having me. It's such a pleasure to be here. I was asked to give a talk on pathways in spine surgery and optimization in the pre, peri, and post-operative settings, and I'd like to talk to you about a pathway that we've implemented at the University of Pennsylvania for the last 2 years now. These are my disclosures, nothing that's germane to this talk. I want to start by just sort of reminding everyone, not that anyone probably needs it, but just the opioid crisis that's been going on. I think there's been increasing awareness. This map shows the opioid-related overdose deaths, and I happen to be working in one of those dark red states in Pennsylvania. In spine surgery, I think we're very much at the center of the opioid problem, and one of the reasons for that is back pain being so common and everyone having, of course, some abnormality on their MRI. I read a very fascinating article about a group of young wrestlers in Florida who were trying to get some narcotics, and they were, saying that they had back pain and so forth. Their MRIs ended up perfect. And what they discovered this method of, I guess when they were in the MRI machine, if they could sort of arch their back and bear down, they would cause the discs to naturally bulge, but that would be enough for them to get narcotics, and they ended up creating this empire of, cartel essentially, shipping these narcotics throughout the country in stuffed teddy bears. It was an absolutely fascinating article. But the point is, back pain and spine, we're very much at the center of it, and it's something to always keep in mind. You probably heard at this point something called Enhanced Recovery After Surgery. It goes by the acronym ERAS. It's catchy. It's not novel. It was pioneered in the late 90s in Denmark by general surgeon Dr. Kaleb. And he identified factors throughout the surgical process that was sort of slowing down the surgical recovery. And he wanted to make sort of minor improvements along the way. Again, this was mostly for general surgery. Colorectal patients is what it was pioneered for. At Penn, we've decided to adopt, we were one of the earlier adopters of this pathway to spine surgery. And what we wanted to do was make a series of total about 16 or so domains that we identified where we could make improvements. I don't know if anyone plays chess, but one of the things, if you studied some of the masters games, what you notice is that it's usually not one single slam dunk move. It's every single move that they make subtly makes an improvement on their position and puts them in a winning situation. I think that's what this is all about, is optimizing every step and really seeing the surgery as sort of a journey in the month or so leading up to it, culminating in the surgery itself, and the month afterwards. So I'm going to go over all these in somewhat detail, and we'll sort of divide them into the preoperative, the perioperative, and the postoperative setting. Preoperatively and postoperatively, one of the things we wanted to emphasize was communication with the patient in a relatively easy way. So we we came up with this text messaging system where the patient can essentially text anytime it goes to My Penn Care, and they can sort of get a text back usually within a few hours. We wanted to really educate them, emphasize education, particularly about surgical site washing. We really want to optimize these patients, and if your patients are anything like mine, none of them are sort of models of health. If their diabetes is out of control, we send them to a diabetes specialist. If they smoke or if they drink in excess, we send them for counseling. If patients are on too much narcotics, we have a special pathway in the pain medicine program where they do such a good job of weaning that off preoperatively, and it makes such a big difference. All patients undergo screening for obstructive sleep apnea, and if they score above a certain score, they also get counseling on that. And lastly, we use something called a RAP tool. You guys may have heard of it. It's to sort of predict preoperatively who's going to need to go to essentially tries to predict where the disposition is going to be afterwards. But really what we're looking at is who's most likely going to need some rehab. I was also part of this committee where we looked at bundled payments, and that's a whole separate talk, but it's something of the future. I think it's coming. And essentially they're going to tell you, okay, well, this pay for cervical myelopathy, I'm going to give you X amount of money. And any sort of readmission and any postoperative rehab is going to be included in that, and decreasing the number of unnecessary postoperative dispositions to rehab centers is going to be something that's real important. We found that with the RAP tool, if we can predict that patients are going to need rehabilitation, there's actually many of them we can somewhat prevent. We can change certain things and encourage them to go home. Obviously, some people need it, and that's just fine. That's not what we're trying to. That's not what we're trying to do. But we are trying to prevent unnecessary discharges to subacute nursing facilities or acute rehab hospitals. In the perioperative period, we focus on a carbohydrate load before surgery and also chewing gum the day after surgery. This really helps with their bowels. This is, again, from the general surgery literature, but it also pertains to our patients. The amount of time we keep patients MPO before surgery, I mean, just don't even get me started. It drives me nuts. Just Wednesday before coming here, I had a patient, I had 4 cases. First patient ate 2 cashews at 4 a.m. because he was so hungry, and they made me wait until noon to start my first case. It absolutely ruined my day. But aside from the inconvenience to us, you know, these patients are old, they're frail, they're 72, and many times they haven't eaten or drinking anything for 10 hours. So their whole insulin system's out of whack. You know, they're absolutely starving. They're probably hypoglycemic. It's not good for them. So we give them a bottle of Gatorade up to 2 hours before surgery, and that absolutely has no negative consequence, and we think has a much positive consequence. The day after surgery, they get chewing gum 3 times a day. In addition, we've really focused on the pain management postoperatively. Patients are not given PCAs. We work with round-the-clock Tylenol, round-the-clock gabapentin, and only opioids on an as-needed basis. So we're not withholding opioids, but it's a PRN medication that they can ask for. We get these patients out of bed real early with aggressive nursing care. In terms of wound care, the bandage comes off on the first day. Foley catheters, it's removed for most surgeries while the patient's emerging from anesthesia. Many patients don't even get a Foley catheter for fairly straightforward procedures. In the postoperative setting, again, we want to really increase the communication between the patient, and that's where the text messaging system comes into play again. We have our team usually call these patients within a day or 2 after discharge, and again at 1 week. They're seen at 2 weeks, and then usually by the surgeon at 4 weeks. So it's, again, something that we try to do to prevent unnecessary visits to the ER. We also have a nurse liaison who is going through the charts. She's identified patients who are at high risk for a readmission. And she found these to be posterior cervical myelopathic patients, tend to be very high up on that list. And so she calls them, checks in very frequently. Again, when the bundled payments come, this is going to be a big issue, whether you like it or not, or whether you're for it, and it will come. And I think the real change is going to be, again, this is a different talk, but it's going to be, they'll probably include the instrumentation within that bundled payment system. But this is something that we all have to be prepared for and not caught off guard. This is all great. I want to talk to you about some of the data that we have. So we did we did a pilot study where at Pennsylvania Hospital, we implemented about 200 or so. We enrolled 200 patients within this ERAS program, and we compared it to a historical control of 74 patients. This is at the same hospital, same surgeons, but again, it is a historical control. And we wanted to sort of dip our toe in the water, see what we had, see if there was anything that we can find. It's fairly small numbers. Here's our inclusion and exclusion criteria. One of the main things is that we excluded patients with liver disease because of the heavy use of acetaminophen. We excluded emergent cases, so cauda equina syndrome. This is only elective patients. One of the things that became an issue later is I do a fair amount of deformity. I've removed my deformity patients from this cohort just because I think it was a little aggressive in terms of the early mobilization and the pain control. Those are obviously a little bigger operations, but the deformity patients were a part of, they were considered elective and was a part of this. Our outcomes, we wanted to look at opioid use, we wanted to look at length of stay, we wanted to look at patient-reported pain scores. The pilot data that we had showed that there was a very significant reduction in opioid use, both in the hospital and at 1-month follow-up. So given that knowledge, we wanted to enroll, we wanted to continue what we were doing, and we continued to enroll for 1 year, and that ended up being about 630 patients. And we compared it once again to our historical control of 74 patients at the Pennsylvania Hospital. In addition, we got a second historical control from our sister institution at the Hospital of the University of Pennsylvania with 60 patients there. This time, different surgeons, same institution, but again, a historical control that was non-ERAS. So I'll refer to the treatment group as ERAS and the other group as controls. This is sort of the baseline demographics between the Pennsylvania hospital controls and the Pennsylvania hospital ERAS patients. Essentially, there's no difference, a minor difference in hypertension, which was slightly more prevalent in the control group. Once again, comparing the HUP controls now to the Pennsylvania Hospital ERAS, these are identical patients is essentially what I'm trying to show you, a very minor difference in BMI, as you can see. The procedures, no difference whatsoever, so the same patient type, same procedure type, essentially. And again, what we found held up very robustly. There was a decreased opioid use in the ERAS group. This was compared for the Pennsylvania Hospital ERAS compared to the Pennsylvania Hospital controls, and it also maintained itself when we compared to the HUP historical controls. This is in terms of in-hospital PCA use, in-hospital morphine equivalents, and also at 1 month after the surgery. Importantly, there was no difference in the pain scores that was reported from the patients despite having a lower opioid requirement. And in fact, on postoperative day 0, the day of surgery, the historical HUP controls had a higher pain than our ERAS patients did. So in conclusion, we've managed to implement, I think, effectively a comprehensive ERAS program that's specific to spine in order to improve multiple domains of the patients, really viewing this as a journey. We showed that our preliminary data shows that there's a very significant reduction in opioid use with the implementation of this protocol, both during the operation and at 1 month afterwards. We're in the process, and this data should be out soon. We have a randomized trial in process now with very large numbers comparing ERAS to non-ERAS traditional protocol patients. Limitations, obviously, this is a historical control group. It's a retrospective study, and there are it's everything I mentioned. There can be minor deviations that's a little hard to monitor everything to an absolute precision. ERAS is an iterative process. We're constantly making improvements. Again, right now we're working on a deformity-specific ERAS program because, again, you just can't mobilize the deformity patients that early, and they do have a higher pain medication requirement. But it's something we continue to improve all the time and try to improve on it. These are my acknowledgments. I particularly want to acknowledge Dr. Zarina Ali. She's my junior partner who's crunched a lot of these numbers and helped push it forward also. Thank you.